Good afternoon, and thank you all for attending today's Journal Club. This is sponsored by the American Thoracic Society's Allergy, Immunology, and Inflammation and Clinical Problems Assemblies. My name is Amit Berry. I'm an instructor of medicine at Washington University School of Medicine in St. Louis, Missouri. And I will be moderating today's webinar along with Vikram Tajwani, who's an assistant professor at the Cleveland Clinic Lerner College of Medicine. Today, I am very excited to discuss the paper entitled Reduction of Daily Maintenance Inhaled Corticosteroids in Patients with Severe Eosinophilic Asthma Treated with Benralizumab, SHAMAL, a randomized, multi-center, open-label phase 4 study published in The Lancet. We are fortunate to be joined today by the first author, Dr. David Jackson, MBBS, MRCP, MSc, PhD, all of the letters. He's a professor of respiratory medicine, consultant in severe asthma and eosinophilic lung diseases at Guy's and St. Thomas's Hospitals in London, and clinical lead for Guy's Hospital Severe Asthma Center. Dr. Jackson's work is focused on the role of respiratory viruses in asthma exacerbations and elucidating mechanisms of severe asthma, Th2 inflammation, and evaluating responses to biologic therapies. We are also fortunate to have two expert discussants joining us today. First, Dr. Helen Riddell, who is a professor at the Macquarie Medical School, she's a professor in the Faculty of Medicine and Health at the University of Sydney and chair of the Global Initiative for Asthma Science Committee. Her work focuses on strategies to improve the management of asthma and COPD, with a particular interest in improving the quality, prescribing, and use of respiratory medications in primary care and population-level monitoring of asthma and COPD through the Australian Centre for Airways Monitoring. She has demonstrated a strong interest in improving communication between patients and health professionals and on making guidelines not only evidence-based, but also practical and practice-centered. Second, Dr. William Feldman, who's instructor of medicine in the Division of Pharmacoepidemiology and Pharmacoeconomics and the Division of Pulmonary and Critical Care Medicine at Harvard Medical School and Brigham and Women's Hospital. He currently serves as the co-chair of the Ethics Committee and associate director of the Ethics Service at Brigham and Women's Hospital. His career is predominantly focused on drug pricing, FDA regulation, pharmaceutical policy, and COPD outcomes. If you have any questions for the presenter or the discussants at any time during the webinar, you can enter them into the chat. You can also unmute yourself at the end of the presentation, as we will be taking and discussing all questions at the end. And now, here to give their presentation is Dr. Jackson.
Thank you very much. Let me just share my screen. Close this other box. Okie dokes. Thank you very much for the invitation to come and present SHAMAL to you this evening in London, this morning in Australia, and in the middle of the day in the US sometime. Over the next half an hour, so I'm going to present this paper. I've sort of intertwined it with some other data to try and sort of enrich the data a little bit more. Firstly, these are my disclosures. This was an AstraZeneca-sponsored study. I have been involved with most of the companies that make asthma therapies. So let's go back to 1958. And this was relevant to this study specifically because it was the first time that eosinophils and steroid response was really connected. Harry Morrow Brown, who was a physician in Derby, the north of England, in his Lancet paper, wrote essentially that the patients who had lots of eosinophils in their sputum were the ones who responded well to steroids, and those who didn't have any eosinophils basically didn't respond at all, suggesting, at least in part, that the reason steroids work is because of eosinophilic inflammation. And we know the eosinophil is a highly complex cell. It produces probably around 100 different cytokines and chemokines and growth factors and enzymes. Its surface is surrounded by numerous different receptors that respond to stimuli in the immune system. But one of these cytokines of note is actually IL-13 itself. And if we think about, the roles of eosinophils in asthma, they've basically been connected to virtually every facet of asthma, whether it is exacerbation pathogenesis through viruses, allergen exposure, mucus hypersecretion, which we know is IL-13 driven, but because the eosinophil is a source, we've seen very impressive results in terms of lung function and so on with eosinophil targeting drugs. Same goes for airway hyperresponsiveness and even airway remodeling. And benralizumab is interesting. And for me, it was interesting right from the beginning because of my interest in eosinophils, because really it gives us an opportunity to create these so-called eosinophil knockout humans. like we have these mouse models, to really understand the role of the eosinophil. So with using benralizumab, we essentially create this in humans. And this then allows us, apart from obviously the benefit for patients, with asthma, it allows us to understand the role of the eosinophil by removing it. And you can see how quickly, through ADCC, the blood eosinophil count suppresses with benralizumab. It's literally within hours. And it's similar actually to high-dose prednisolone in that effect, which is why, of course, high-dose prednisolone is such an effective treatment for an acute exacerbation of asthma. So we do know, though, unfortunately, steroids come with loads and loads of side effects. There's been several studies published showing this. This is perhaps one of the most recent, which from the UK, one I was involved in, almost 500,000 patients. And here we were looking at a comparison and the hazard ratio of patients with asthma exposed to oral corticosteroids compared to those with asthma not exposed to oral corticosteroids. And you can see for these 7 different complications, comorbidities, along the bottom, that the greater the exposure, the greater the dose. And to put this into perspective, if you, for example, have a patient who has had 2 courses of prednisolone each year for 4 years, based on the fact that a course, let's say 40 milligrams per week is 280 milligrams, you're already over 2 grams. So significant risks. But what we also know is that actually already from 2000, there was evidence that inhaled corticosteroids at high dose was also associated with risk. This was the first study from Anne Tattersfield that I'm aware of, who was based in Nottingham in north of England. And here, again, she showed increased association of increased risk of bone mineral density loss with increasing risk. And interestingly, 10 years ago, many of you will remember perhaps this front cover of Lancet Respiratory Medicine Journal, which I think was very sort of compelling in its image of the impact in kids of high-dose inhaled corticosteroids as well on growth and on bone mineral density. And more recently, Richard Beasley and others published this important review, again highlighting the risk of high-dose ICS and systemic side effects, adrenal insufficiency, cataracts, osteoporosis, again related to fractures, and diabetes. So it's been interesting to think about the potential that when we move up this treatment escalator to step 5 for patients with severe asthma who are requiring high-dose ICS LABA, could potentially, by starting a biologic, we can then reduce that back down to a safer dose rather than keep them exposed to that high risk. It's also important to bear in mind that, as we know, patients are rubbish at taking inhaled therapy on a daily basis. This was data from the US that was published almost 20 years ago now, 5,500 patients. And you can see, across different age groups, genders, doesn't matter, percent adherence was really poor. It was 20, 25%, and loads of studies have shown the same. Now, arguably, certainly in the UK, you're not allowed to prescribe a biologic until you've objectively confirmed good adherence to ICS. But one of the questions that we wanted to ask in our center several years ago was whether patients on a biologic become less adherent to their inhaled corticosteroids following initiation of biologic therapy. And if so, does it actually matter? And the pharmacist I work with at Guy's first looked at our patients, Granida Nkono is her name. We first looked at this with mepolizumab. And essentially, we took a group of patients who had completed a year of mepolizumab, and we divided them into those that had good adherence based on at least 75% ICS use based on MPR over the year, pickups over the year, suboptimal 50 to 75%, or poor less than 50%. And what we saw, interestingly, was that only the patients who continued to use ICS reasonably regularly actually had a good reduction in exacerbations, and those who stopped using it on a regular basis didn't get that benefit. Now, a year later in the UK, we then had access to benralizumab, and we repeated this study exactly the same. And it was a surprise to us, I have to admit, to see something quite different, which was even the patients who stopped using regular ICS appeared to derive a similar benefit in terms of exacerbations, suggesting possibly, because we know mepolizumab only gets rid of approximately half your eosinophils in your airway, benralizumab pretty much gets rid of all of them, perhaps that residual airway eosinophilia is relevant when you come in terms of ICS. And if you take away your ICS, perhaps virus comes along, those eosinophils become activated, there is more IL-13 in the airway, and so on, and develops. And this actually led to literally the back of a napkin design for this study, SHAMAL. So this is, as described, as read out earlier, a phase 4 study, randomized, multi-center, open label, taking patients on benralizumab with severe eosinophilic asthma, and then randomizing them either to continue high-dose ICS/LABA in the control arm, or a progressive wean down from high dose to medium dose to low dose to then anti-inflammatory reliever only. It was a 3-to-1 randomization, and it was done over a 32-week reduction period. And then we watched patients for a further 4 months to assess whether they remained stable or not on whatever dose they got down to. The key inclusion criteria were that this was, they were adults. Of course, they had severe eosinophilic asthma because they were on benralizumab. They were already on a high-dose ICS/LABA. They'd had a minimum of 3 doses of benralizumab. Most of the patients actually had had it for about a year before they went into the study, and they were clearly doing well on it. They were well controlled with an ACQ of less than 1.5. They hadn't had an exacerbation in the previous 3 months, which you can see is one of the key exclusion criteria there. Didn't have any other major respiratory illness, and they could not have had more than a 20-pack year smoking history. The primary endpoint was the proportion of patients reducing their ICS/LABA maintenance dose to down, essentially to the different categories of medium dose, low dose, and as needed. Secondary endpoints included that reduction, the proportion at the end of the study at the year, week 48, and then looking at the total daily dose, the ACQ change in lung function, and change in exacerbations. So this is essentially what it looked like. 208 patients essentially were screened and included. And as I mentioned, it was 125 in a 3-to-1 randomization assigned to treatment reduction versus 43 to the reference group. As with all studies, there were a few dropouts here and there, but generally the majority completed. This is the baseline characteristics. I'm not going to go through this in detail. Just to orientate you, column 1 is the treatment reduction arm, then the reference arm, and the total. Standard group of patients, pretty much. The average age for an asthma study, in the mid to late 50s. Just over half the patients were female. 3/4 were Caucasian. The study was done over 4 countries: France, Germany, Italy, and the UK. They were on benralizumab, so nearly all the patients obviously had 0 eosinophils. You can see, though, that the range went up to like 860. I did look into this. There were basically 2 patients who must have developed anti-drug antibodies, but we were unaware of it. But that's why you're seeing an upper limit on the range of 860, even though they were on benralizumab. Everybody else basically was close to 0, as one would expect. Lung function was about 75% predicted. Phenos were pretty low, actually, 25 to 30 range. The exacerbation frequency the year before starting benralizumab was around 3, but the ACQ-5 on treatment was 0.5. So these, as I said, very well controlled, but clearly patients who needed benralizumab in the first place because of that exacerbation frequency. This is the algorithm of what happened during the study in terms of stepping up and stepping down, and what investigators were instructed to do. So the first division is if they had an exacerbation or not. If they did, there was no further tapering. An investigator at that point decided whether the dose needed to be increased or whether the patient could remain on the same dose. If they didn't have an exacerbation, it came down to the ACQ. And here they used the MCID of 0.5. If there was an increase of at least the MCID or more, then the next step was looking at how many reliever inhalations were used over the course of the week. If it was 8 or more, tapering was stopped, and again, the investigator was decided whether they needed to go back up to the previous dose or stay put. Or if there were less than 8 or 8 or less inhalations over the course of the week, the tapering was delayed, and then remain on the dose until the next visit, essentially, where it could then be reevaluated to see whether it can come down. Then going to the right of the algorithm, if there was no ACQ rise of at least the MCID of 0.5, again, inhalations were looked at, And if there was no more than 8, patient reduced. If there was more than 8, the tapering was delayed. Now, the Symbicort, the formoterol budesonide that was used, had a Turbo Plus e-monitor on it. So everybody in the study had an e-monitor. So we could exactly, which was time-stamped every time they used it. So we knew exactly how many patients, how many inhalations each patient used. We also knew when they used it in relation to the FEV1 measurements, because they were told not to use it within 12 hours. Okay, and this was verified by the time stamping of it. So these are the main results. Panel A is looking at the proportion of patients who could reduce to the different stages. So overall, you can see 92% of patients could reduce the ICS formoterol. 15% got stuck at medium dose. They couldn't reduce further for one of those reasons I mentioned earlier. Everybody else, the remaining 85%, could actually reduce below medium dose. 17% got stuck at low dose. The majority, as you can see, were able to reduce all the way to anti-inflammatory reliever. Excuse me. The pie chart on the right is essentially saying what happened during the maintenance phase. And the green, which is virtually everybody, is no change. So whatever they got down to at the end of week 32, they were happy. They appeared to be fine to remain on, and they didn't need to go back up or anything else. Panel C at the bottom is simply showing the mean daily ICS dose over the course of the study, clearly showing reasonable stability in the reference arm as one would expect, and this reduction in the other arm. This is the symptom score, so the ACQ. Just to remind you again, the ACQ MCID is at 0.5. So although there is a numeric apparent difference here, it is very negligible. 0.2 is neither clinically or statistically significant over the course of the study. These are exacerbations. So the thing to focus on here is the entire study period, which is the bottom of table 3. And you can see here, when you look at the annual exacerbation rate, they were the same, 0.14. So essentially, there was no increased rate of exacerbations in the treatment reduction arm compared to the reference arm, even though, as I showed you, 61% got all the way down to anti-inflammatory reliever. But all good studies need a but. The but here is the lung function. And what you can see is in the reduction arm, there was a fall in lung function compared to the reference arm. And on the right, you can see, not unsurprisingly, because of the relationship between ICS and FeNO, there was a rise in FeNO. And when we then broke this down into the different ICS groups, you can see in red here that actually it was only the group who got down to anti-inflammatory reliever only, who were no longer on any regular maintenance ICS dose, that were the ones who lost the lung function. Everybody else, even those in green, low dose, didn't actually lose significant lung function. And on the right, you can see that these are the ones who had the biggest rise in FeNO, reasonably decent jumps of around 30 to 40 parts per billion. And these two independent metrics were related. This is a plot showing the change from baseline in FEV1 at week 48 compared to the fold change in FeNO, showing a negative correlation. And if I then show you this by each patient, so you can see more clearly, just to orientate you here, panels A and B, the top two is the absolute FeNO, week 32 in panel A, week 48, panel B. Underneath is the delta, the change from baseline in FeNO, week 32 and week 48. And the reason it's important to look at this on an individual patient basis, I think, is because you can clearly see there are some patients who had a pretty good going FeNO who didn't actually lose any lung function. And there were also some patients who didn't have such a high FeNO. It was elevated, but not that high, somewhere between 25 and 50, who actually lost quite a bit of lung function. So although the two are correlated statistically, it's not a perfect relationship, clearly. Now, just moving aside for a moment, what's interesting, I think, is that the relationship between lung function decline and T2 inflammation is not new. But what is interesting is that when we look prior to SHAMAL, we saw this relationship both with blood eosinophils and with FeNO. These are the three main studies that it's been shown in. Blood eosinophils on the left, the higher the blood eosinophil count, the greater the lung function decline. The same for FeNO. But until SHAMAL, it wasn't actually clear that this was primarily driven by IL-13 and FeNO, because in SHAMAL, they're on benralizumab, they don't have any eosinophils, yet you see this relationship. So although the two markers often track together, it's fundamentally being driven by FeNO, not eosinophils, actually. And this is the most recent study that shows this, and the most important one because it's over 10 years from Copenhagen. And this is showing the relationship between FEV1 decline, mils per year over a decade, and FeNO. Again, showing the higher the FeNO, the greater that lung function decline. And what's interesting is in the bottom panel, they broke it down into the different groups from what they could gather, the controls who didn't have any airways disease, patients with COPD, patients who are not classifiable because it wasn't really clear from the data they had available whether they had asthma or COPD or not, and then two groups of asthmatics. And here they were the asthmatics with persistent obstruction who had this lung evidence of airway remodeling, and those that actually had pretty normal lung function, that had full reversibility. And if you think about those two groups, what's interesting then to think about is the idea that for any given FeNO, there is a subgroup of asthmatics who appear to lose more lung function, who are more susceptible to airway remodeling lung function decline over time. And then bringing this with MEPO here, this is the 5-year data again, looking at it in a slightly different way now that we've got SHAMAL data. In the top left panel, we're looking at exacerbations over the 5-year period, which is stable. In the top right, we're looking at symptoms over 5 years, which is stable. But if you look at lung function, there is this progressive decline. And I do wonder, they didn't measure FeNO in this data, in this cohort, but I do wonder that if you split those patients, if FeNO had been measured, whether we would see a pretty flat line and this even more accelerated decline in the FeNO high patients. Coming back to SHAMAL for one of the supplementary figures, which I think again is really interesting, which is this one. This is showing in the anti-inflammatory reliever group a split between those who had minimal use, like a maximum of 4 inhalations per week of anti-inflammatory reliever, not being on any other ICS whatsoever, and those who in response to symptoms had 5 or more inhalations. And what you can see is that the ones who had the fewest symptoms, bearing in mind that this is anti-inflammatory reliever, it's in response to symptoms, were the ones who actually had the greatest lung function decline, suggesting it is happening subclinically, actually, in many patients. And in relation to that, I just want to highlight this study from more than 20 years ago. People talk about remission all the time nowadays, and it's in the context of biologics, but this was before biologics. Here they defined remission as an absence of asthma symptoms, despite not taking any asthma medication for at least 1 year. And the reason I'm showing you this is if we look on the right at blood eosinophils on the top right, it's FeNO on the bottom right. Remission, patients in asthma remission in black, patients not in asthma remission with asthma in the clear or white dots. And you can see there's some patients there in remission who have pretty good going eosinophil counts, pretty good going FeNO. So again, there's this subclinical background inflammation, which I think is increasingly relevant in ways that we need to discuss. Now, this SHAMAL was also the first study to actually prospectively look at remission. And this is, again, one of the supplementary figures looking at the different domains of remission. So starting, so the top panel A, you're looking at the treatment reduction arm. Panel B underneath is this reference arm, the patients who continue to high-dose ICS LABA. There's week 32, week 48, but just basically concentrate on week 48. So it's the darker colors of each one. And again, you can see majority exacerbation-free, majority have ACQ less than 1.5. Similar numbers have an ACQ less than 0.75. And then the first difference really is when you look at the proportion who had an FEV1 decrease of 10% or more, and then you see the difference between 72% and 79%. And then, going to the right, the second from last is the proportion of patients who are exacerbation-free, have an ACQ less than 1.5, and didn't have that decline in lung function. And then you see the difference between 54% and 68%, and with an even more rigid ACQ cut of 0.75, you see that difference again of 14%, 50 to 36. Finally, just to show you the adverse events were similar across as they were reported in the study. There was no increased rate of adverse events in the treatment reduction arm, and similarly in the reference arm either, when you think about more ICS exposure. So to summarize, 85% of patients with severe eosinophilic asthma, well controlled on benralizumab, could reduce their ICS to below medium dose without loss of symptom control. And this, as I showed you earlier, is important because all the ICS-related risk is at medium to high dose. 90% approximately remained exacerbation-free, and I think this really does speak to how central the eosinophil is in exacerbation pathogenesis, and why benralizumab and other drugs that target eosinophilic inflammation are very, very helpful. Evidence of accelerated lung function decline was seen in a subgroup who were able to reduce all the way to anti-inflammatory reliever. And those patients with the least use, the least ICS exposure, were the ones who had the greatest FEV1 fall, suggesting, given that it was anti-inflammatory reliever, that it was largely subclinical. And I think what the study shows is, and really from a mechanistic perspective, what it adds is we see the relationship between lung function decline and FeNO in benralizumab-treated patients really supports an IL-13-associated eosinophil-independent mechanism. And, this aspect of asthma pathobiology actually really only appears to require low-dose ICS to control, because, the patients on low-dose ICS didn't really appear to lose lung function, suggesting whilst you may need medium-high doses for symptoms, exacerbation control, maybe perhaps the airway remodeling IL-13 part may not. I'll stop there. Thanks very much.
Perfect. Thank you so much, Dr. Jackson. That was really a wonderful presentation. I think for all of us, as soon as we saw this study, we're just so enthused to have some evidence behind, navigating these patients and kind of corroborating a lot of our clinical observations, which it sounds like prompted this question in some of your early studies in this to begin with. So with that, I'll turn it over to Dr. Riddell and Dr. Feldman for any comments. Then we'll welcome any questions from our audience who are welcome to unmute or type it in the chat.
Good. Well, thanks very much, David, for that presentation, which was excellent, not only for the description of your own study and the findings, but also some of those background references, which are really important to look at. This study highlights the importance of beer coaster designs. The concept for a study like this being developed as part of essentially the sort of discussion we do all the time with colleagues. In fact, maintenance and reliever therapy itself originated on a beer coaster. So this is another really interesting study for that reason. And it fills some very important gaps, more than just one gap. It's the beginning of filling several important gaps in terms of treatment recommendations. So first, a declaration that this is something that I practice do in my own clinical practice. So although I noticed you said that Gina recommends reducing the ICS dose without any evidence, there's actually no evidence to continue high dose ICS. So Gina recommends individual down titration of medications when asthma is well controlled, and this is a specific example of it. But as you say, it's important to have evidence in this very challenging population. So in my own clinical practice, what I see is that that you do have to individualize the dose reduction. And that's consistent with what we see when we increase the inhaled corticosteroid dose in any patient. Some are remarkably responsive to even low doses of inhaled corticosteroid. And by the time we get to biologic therapy, we know that these patients are relatively refractory to corticosteroids, not necessarily completely refractory. There's a lot of things I could comment on, but I just commend you for doing the study and doing it so well, so that because from the documentation that you've undertaken, we can learn a lot more. One of the things that it reminds us of, though, is how blunt our tools are when we want to carry out dose reduction. So the ACQ, for example, you can get the minimal important difference at a group level is 0.5. Well, you can either get a 0.2 difference in an individual patient or 0.4 or 0.6. You cannot get a 0.5 in an individual patient. You can get a change of 0.2 just simply by the patient ticking once little rather than very little for one of the symptoms. So it's, it's that subjective. FEV1 itself is a blunt tool. Given the variability that we see from visit to visit, if you have very good lung function testing in a lab, it's more consistent from visit to visit, but you still have to assume that any particular measurement is, say, plus or minus 200 mils from another measurement. And FeNO itself is also a relatively blunt tool in terms of the pathways that it reflects. So one of my take-home messages is a call for more specific or broader biomarkers that tell us more about the different pathways that we see. I just want to clarify one methodological issue, because something you said suggests that it might be different from what I perceived from the paper. So in your algorithm, the division by number of inhalations, so it says the weekly average number of ICS formoterol inhalations per day was greater than or less than or equal to 8. From what you said, I suspect that's per week rather than per day. Is that correct?
Yes, per week. Yeah.
Okay, right. So that's something you probably need to fix, because it's in several places in the paper, and that somewhat distracted me in terms of working out the how these patients compared with others that I'm aware of. So thank you for that.
Thanks for pointing that out, Helen.
Yeah. Okay. Good. Look, I think I'll stop there, because I'm really interested to hear comments from others about the things that that have been highlighted. But again, congratulations on doing the study, and for the very many interesting discussions and beer coasters that will likely follow from it.
Thank you.
So maybe I'll just say a few words, maybe add some more beer coasters for future studies. But thank you so much. This was, I love this study. I'm going to make a few comments from a policy health services standpoint, because that's what I study, and really US focused, because I focus so much on the US healthcare system. So apologies ahead of time, but our pharmaceutical system, I think, functions perhaps worse than almost every other pharmaceutical system. So, so perhaps most relevant, but sort of a few high level comments, which is, in this paper, it was a dry powder inhaler. The ICS formoterol was a turbuhaler, a dry powder inhaler. We do not have that in the US. It's just, we only have ICS formoterol in metered dose inhalers. And so I think what's one exciting thing to me about this study is as we think about reducing ICS, particularly via metered dose inhalers, is the environmental impact of decreasing use of metered dose inhalers to the extent that we can, based on studies like this. So I just to point out that as one, not patient specific, but sort of policy relevant effect of minimizing steroid use at a population level via metered dose inhalers. The second one is cost. So we pay lots in the US for inhalers. There are very few generic inhalers available in the US. The 3 of the 4 big brand name manufacturers just said they would cap out-of-pocket costs at $35 per month just in the last few months. But these still cost the healthcare system a lot of money. So I think when I see a study like this, it's wonderful, because, to the extent that we can reduce the use of steroids, that also means potentially lowering costs. And then a third thing that you alluded to at the beginning, Dr. Jackson, was these questions about adherence. And I wonder, a lot of these patients are on multiple medications. And so decreasing medication burden can help people afford other medications that they might not otherwise be able to afford. It can help them, simplify their regimens in a way that might actually benefit them adherence-wise across other medications. So I'll stop there. One last thing that a few folks have mentioned, I guess, from a coverage and policy standpoint, a challenge is that if you get people off of steroids, off of inhaled corticosteroids, does it now look to the insurance companies in the US like you don't have severe asthma anymore, and therefore we're not going to cover your biologic, which of course feels like the worst possible outcome. And I don't know, maybe other folks have comments on that. I don't know how common that is. And it seems like a terrible outcome. So, one that should be addressed ideally, with insurers to make sure that the data like the one that we're talking about today are out there so that it is known that this is this sort of a strategy that we should be pursuing. But yes, just so I'll stop there. And I guess one question maybe I can ask is for Dr. Jackson related to table 3. There were overall similar numbers of similar rates of exacerbations, but you see more exacerbations in the intervention group in the reduction period and then fewer in the maintenance period. And I was just wondering if you could comment on that a little bit.
Yeah, no, it was interesting. I do think it was just a slightly odd anomaly. That also sort of a 16-week period is not such a long time. You're going to get these slight differences, but I think it's an anomaly rather than clinically significant or relevant. Over the course of 48 weeks, they're basically the same. But yeah, it's the fact that it flipped also, it just doesn't really make sense mechanistically.
Thanks.
Thank you for
So
that.
I can just follow up on a couple of the points there that Dr. Feldman has made. So with regard to the environmental impact, so we've just recently published a paper in ERJ looking at the carbon footprint in mild asthma of the GINA track 1 approach of as needed only ICS formoterol. And it reduces the carbon footprint by 96% compared with short-acting beta agonist alone, or compared with the standard of care of regular daily inhaled steroid with SABA reliever. It is really important that we think first about what's the medication that's appropriate for the patient, and then out of the inhalers to which that patient has access, which can they use and which has the lowest environmental impact. But it is really important in terms of access to suitable inhalers in other countries. The other thing I just want to comment on is, as you said, Dr. Feldman, many of these patients are on multiple medications. So what do you do first when you're looking at a patient whose asthma is now brilliantly well controlled on a biologic? What do you reduce first? So we've taken a very pragmatic approach to that in the GINA severe asthma decision tree. And we start with oral corticosteroids. That's the first thing you want to get rid of because of the extreme risk of even occasional courses and certainly of any maintenance treatment. So start with oral corticosteroids. And then after that, you really need to decide based on things like cost to the patient, patient willingness to take it, side effects, and the benefit that the patient had when they first started a treatment. So there's a subgroup of patients who, when you started, way back, perhaps, when you started montelukast or you started a LAMA, say, that really changed my asthma. And so in that situation, if you've got a choice, we would suggest you go for one where, there was a ho-hum benefit when it was originally introduced. And we would probably suggest getting rid of those extra medications first before reducing the ICS dose, simply because these patients have already declared themselves as being relatively refractory and therefore needing high doses. But once you do it, based on the characteristics of the patients that are prescribed biologic therapy, our suggestion in 2023 was not to go below medium dose ICS LABA. Obviously, that's something that needs to be reconsidered with increasing evidence, both from our clinical practice and from this study, that in some patients you can go lower, but it must be individualized. So the group level changes are really important in showing that you can go too low. But in individual patients, we do need better tools for working out when to stop a dose reduction. Thanks.
And that's actually exactly why, those looking at the correlation plots, and so you can see the individual patients, you can see the range there that some patients didn't lose any lung function. despite having, decent FeNO levels, and others did at more modest levels. So, one has to, when you follow up these patients on biologics, you have to, even if they say, I feel fine, I'm not having any exacerbations, unless you do that FEV1, unless you do the FeNO, you're simply not going to know whether they've got that subclinical decline, and are at risk, essentially.
Yeah, I'd love to see breathomics used in a situation like this to give us more information about the underlying pathways. I mean, this sort of study is a real trigger for research to say, okay, what's the pathway that we've knocked out, not just eosinophils, but what other parts of the pathway, so that we can then refine our knowledge about who needs what treatment.
Yeah, absolutely. No, there's a subgroup there who are losing lung function for an equivalent level of T2 biomarker, in a more accelerated rate than others. So there is another unknown that relates to airway remodeling that hasn't been identified and relates to risk, future risk for these patients. That's definitely what needs to be looked at. Absolutely.
One other thing that could potentially help, and I do this sometimes in clinical practice when I have the resource, is to use home spirometric monitoring. So a very long time ago, like more than 20 years ago, we did a down titration study from very high dose inhaled corticosteroids. So this predated the availability of ICS-LABA for us. And what I found was that a patient could, their lung function on twice daily spirometry could decline over a period of 6 weeks before they actually developed more symptoms. And in those patients, even when you looked at their FEV1 before and after that period of decline, the change was only 7%, which is undetectable by clinic measurement of lung function because it is so imprecise. So I would be looking in future studies, it'd be really good to have home monitoring to see if we can better identify the point at which we should say, don't go any further with this. And of course, what the patients themselves do is another thing. So a couple of weeks ago, I had 2 patients who'd done extremely well on biologic therapy, both of whom had, without permission or instruction, completely stopped their inhaled corticosteroids. One of them had an FEV1 of 105% predicted, low FeNO, no exacerbations, and an ACQ of 0. And the other one had redeveloped reversibility of 25%, had symptoms most days, and had lost lung function. So we have to, there's a lot of counseling involved in terms of managing a strategic and careful dose reduction.
Absolutely.
I had a question. I know that there are multiple phenotypes in asthma, and then there's folks who develop reversible decline in lung function, and then progressive non-reversible decline in lung function. Is there any follow-up of these patients that's shown whether this decline in lung function was reversible? For example, did any of them get worse afterwards and then get put back on higher dose steroids or even systemic corticosteroids and see any changes to their lung function? And sort of as a corollary to this, does this change monitoring practices for folks who are on biologics, and if so, should it change treatment practices with their other inhalers?
Yeah, no. So there wasn't, unfortunately, an extension study. Hindsight's wonderful, and I wish I would have planned one based on this. And we just need to do these studies now to understand that a little bit more. But there wasn't an extension study. But I do. I think what the lessons, as I mentioned already, one of the key lessons is that just because a patient says, I feel fine and not exacerbating, it doesn't mean they're out of the woods. And, there is different domains of risk, but lung function decline is a very real one. And if you kind of assume everything's fine just because the patient says, I haven't got symptoms, what we've seen, as I showed, the patients who used the least anti-inflammatory reliever were the ones who lost the most lung function. And, you use 5% this year, 5% next year, 4 years, you're 20% down. So it's really important, these patients on biologics and non-biologics, that we do objective measures of lung function and T2 inflammation, every time we see them. to ensure that they are not in that subgroup, because at the moment we simply don't have the tools to otherwise predict it. You know, as I showed, just because they had a FeNO of 50 didn't mean they were definitely going to lose lung function. And others who had a FeNO of 35 lost loads, some of them. So, you know, it's very, very important from that perspective. We have to remote monitoring, which has become really fashionable since the pandemic, understandably, is fine for some patients. But unless you do periodic measurements, you're going to miss the ones and allow them to lose that lung function potentially irreversibly.
Thank you for that, Dr. Jackson. I'll, Dr. Krings, I see your hand up, so please, I'll turn over you for your question.
Thanks, Vic. I just wanted to say thanks for doing this study. I also thought it was not entirely surprising, but very fascinating. The flip side of it is, I think one of our beliefs is that part of the reason that benralizumab and similar drugs are so effective is because people only have to take 8 weeks. And we know that people aren't adherent to their maintenance inhalers every day, even though we try to get them to be adherent and assess for that. And there's increasing use of electronic sensors. And I know our local Medicaid will be positive. People are refilling their maintenance inhalers before they'll even approve benralizumab. I just wanted to get your thoughts on how you or the other asthma providers, how they are treating the space now since we have this data. So you have somebody on benralizumab or another anti-IL-5 or dupilumab or Tezi or whatever, and then they're well controlled. They've been well controlled for a year, and you're starting to, they're just on let's say they're on high dose smart therapy, and you're starting to think about backing off their dose. I guess the way, recognizing this is just one trial, I feel like I would be moderately comfortable with maybe backing down their dose. 1 puff twice daily of budesonide formoterol, and then as needed. But then I feel like once you get down to just the as needed, maybe that makes me a little bit more nervous, because you had that signal for a more of an FEV1 decline. So I guess, how are others handling these people that are on something like benralizumab that are well controlled for a long time? Is this data convincing enough for you, or et cetera?
So, you know, I think in my practice, the lowest hanging fruit is getting them off high dose to medium dose without question, because, you know, all the risk is there mainly. Moving from medium to low, I still think is achievable based on SHAMAL in 85%. But one has to remember that to get into SHAMAL, firstly, you were already showing yourself to be a super responder to benra. You had low ACQ, you hadn't had any recent exacerbation, so you're already in that subgroup. And then you've got to remember that the study's only over a year. So the data's reassuring, but, you know, personally, I'm happy to move down to low dose, but there has to be follow-up in place. And, you know, most importantly with FEV1. Anti-inflammatory, the issue is, as we've discussed, patients naturally are going to go to anti-inflammatory reliever themselves. That is like natural behavior when you feel good on your biologic. So I think what SHAMAL is, one of the reasons actually I really like SHAMAL, not because it's my study, but because it basically is telling us whether we need to worry about what patients naturally do. And what patients naturally do is essentially that treatment reduction arm. And so what it's telling us is, okay, they're going to do this anyway, many of them, but we just need to pay attention to the FEV1 even when they say they're fine. That's you know, one of the key take homes, I think.
Then I suppose piggying onto that a little bit, and Dr. Welcome, your thoughts on that question. Is this, you touched upon the MEPO data, but how much of this can be extrapolated? James had mentioned, you know, whether it's tezepelumab or even omalizumab, going back to IgE therapy, how much of this can be extrapolated to that, or should this really, at least given the kind of more pronounced eosinophil depleting effect of benralizumab, be considered predominantly a benralizumab specific finding as opposed to a biologic specific finding?
Yeah, there's a temptation to say it's probably the same with all, but I don't personally think that. I think that when we looked at initially our MEPO data, we didn't see the same thing. We did see that there was increased exacerbations when patients stopped using their ICS. And, you know, when we look at kind of, although it's uncontrolled, the switch data that we've seen, we just published in ERJ, the Jalok study, there were about almost 300 patients who were switched from Mepo to Benra, who were still exacerbating on Mepo, who stopped exacerbating largely on Benra. I think there is still some residual eosinophilic inflammation on Mepo that is relevant. And I do worry that that then makes patients more susceptible, a subgroup, not everybody, but a subgroup who then wean off their ICS. It's interesting with Dupi and Tezi as well. I've seen patients become less adherent and their phenos go up on both Dupi and Tezi. And it's actually one of the easiest ways to identify non-adherence to ICS after starting Dupi and Tezi is looking what happens to their pheno when it goes up instead of coming down. Or at least it comes down and then it goes back up. And when we put patients on e-monitors, which we do have access to in our clinics, we've seen it then go back down to where it was before. So it is reflective. So I don't think just because Tezi and Dupi both target IL-13 that somehow we're not going to see the same problem there, unfortunately, because it's not complete IL-13 suppression. Otherwise, you would pretty much get a flat pheno, which is what you get with lebrikizumab from the studies often in the higher doses. So I think the studies need to be done. Look, the Tezi study is called Arrival. It's happening this year, the end of this year. So that's going to be done. I don't know if there's a Dupi study planned yet, but it should be done. But again, I do still think probably all the biologics, maybe not lebrikizumab, it's the only one I'd accept, but all the others I think you probably get down to medium dose fairly safely.
Thank you. And Dr.
Is
Bell,
my
please.
view without evidence.
I'd just like to make another comment there in terms of our strategy for dose reduction. So remember that in SHAMAL, there's actually a second intervention, and that is that the patients were switched to maintenance and reliever therapy. So this is, I think, probably the first study that has taken patients who are already on a step 5 treatment and have switched them to maintenance and reliever therapy. It shows that it was certainly able to work. And as it does in clinical practice, it provides a safety net during down titration. So we can't assume that down titrating a patient, so if you start out with the same population at randomization in SHAMAL, we can't assume that if you down titrated with a SABA reliever, you would have the same outcomes as you saw here in this. So the rationale in GINA for extending the reliever of ICS formoterol across to step 5 is that if a patient needs a biologic therapy, it just doesn't make sense to then also switch them back to a SABA reliever. So essentially, there's no reason to discontinue maintenance and reliever therapy when you add a biologic. But this study is a reminder that SHAMAL is specifically in patients who are getting those as-needed doses when they have more symptoms or encounter a viral infection or allergen, etc. So it was an important part of the intervention, and I really particularly appreciated that you took that approach. Thank you.
Yeah, no, thanks. It is an important point, and it hasn't actually, Helen, come up before in that way, but it is relevant, and the fact that down titrating is not just about the maintenance dose; it's about the fact that you are using anti-inflammatory reliever as that cover. Yeah, absolutely.
Thank you. I'll move over to the chat now, and Dr. Jackson, you touched upon some of the kind of original definitions of remission. We have a question from Dr. Akinroy. Curious if you have thoughts about the ongoing focus on asthma remission, given that this is showing we may need to continue ICS in a subgroup of individuals, it seems like.
I think the remission debate, I think SHAMAL has been really important for the remission debate, actually, because I do worry that there's such a focus on clinical remission in over a 12-month period that the ongoing consequences of subclinical inflammation is forgotten. And, it's a complicated concept, remission. And, it's fine if you want to use remission just as a target to compare drug A and drug B and as a new metric. But if you actually want it to be meaningful for the patient in terms of risk in their future, then you can't ignore subclinical inflammation that drives lung function decline. I mean, that's relevant for the patient. So just because they got an ACQ of less than 1.5 or 0.75 and they're not exacerbating, but yet they're losing lung function year on year because of they're running phenos of 80, you can't just pretend that's not there and call it clinical remission. I think it's nonsense, personally. So I think it's really important to consider biological remission, and I think this underpins why it's so important, this study.
Thanks. I'll move on to a comment from Dr. Johansson, just kind of concurring a little bit with the not complete mepolizumab effect with persistent eosinophil activation in the airways, maybe not in the blood. And then moving on to a question from Dr. Foyer. So were the patients with suspected benralizumab anti-drug antibodies, so this is referring to that group with the high, eosinophil count up in 860, the group with the fall in FEV1?
There was literally like 2 patients out of the whole study. So I actually don't even know which group they were in, but there's only 2, so it wouldn't have made any real difference, I think. Yeah.
Perfect. And then a question for Dr. Feldman, and Dr. Feldman, you touched upon this as well, and I'm just echoing with what Dinah has put in there, is that we have some patients whose insurers for their kind of coverage essentially need them to have essentially have that seen that their prescription is being filled in terms of being adherent with the diagnosis of a chronic disease. So her question is about how to circumvent drops in insurance coverage of biologics once the ICS lab dosage may not be refilled on that 90-day or 30-day cadence as we are able to hopefully taper them.
I don't have a great answer other than perhaps give them Dr. Jackson's email and send them the study. I mean, I think it requires education of the payers in a way, and so it's such an uphill battle. But the more that the research gets disseminated, I think the easier it gets. But I think it just requires sort of battling with prior auths and the payers on each. With each patient, unfortunately.
There must be like other disease areas where it's the same. Like we think like severe eczema, atopic dermatitis, like methotrexate first, then dupilumab. You shouldn't need to remain on methotrexate once you've had an amazing response to dupilumab. I mean, it's a bit ridiculous. Or prednisolone with rheumatoid arthritis, and then have TNF or something.
Well, I think to that end, educating the payers can sometimes feel like an oxymoron in the United States, and so this is somewhat of the challenge that we sort of have to go through.
So perhaps we need a concept like the artist formerly known as Prince. So this is formerly severe asthma. We would still keep that label of severe asthma, now very well controlled on, and then the biologic therapy, because of that issue around the perception that, their asthma is nothing now.
And I guess I would make a plug. This has come up just for advocacy with the payers. It's come up with the Flovent discontinuation with pediatric pulmonologists in the US. So GSK pulled Flovent products from the market, and it's been a big issue for pediatric pulmonologists. And I know 1 or 2 who have been working with the payers and have been writing emails, and they've been at least hearing them out and responsive. So to the extent that people have time after clinic to sort of fight that battle, like it's only from groups like this that payers are going to hear the data, and so I just a plug to sort of advocate as best we can.
Perfect. Well, I want to be respectful of Dr. Riddell's morning and Dr. Jackson's evening. So with that, Amit and I would really like to thank all of the authors for participating, and the panelists, and in particular Dr. Jackson for the excellent presentation and an elegant study, just answering an important question to all of us. And again, just reiterating our thank you to Dr. Feldman and Riddell for the wonderful insights, as well as all of you that joined and provided questions as well. For ATS attendees, feel free to reach out to myself or Amit if there are any particular journals you're interested in, articles, you're interested in hearing about. And with that, we'll conclude and just thank you all again. Really learned a lot.
Thanks very much.
Thank you.
Thank you all so much.